Thank you for joining us today to learn about DCD, or organ donation after cardiac death. DCD is the recovery of organs for transplantation after pronouncement of death based on cardiac arrest, not on the traditional brain death. This has become an increasingly important topic since the 1990s due to the rise in demand for organs. Over 108,000 people are currently on waiting lists for organs according to the Organ Procurement and Transplantation Network. 95% of donations come from patients declared brain dead. However, it should not be forgotten that patients who die from cardiac death can also be good candidates for organ donation. These patients are those that have sustained devastating and non-recoverable neurological injury that does not culminate in brain death. The families then must elect to withdraw life-sustaining therapies. There are many things to consider with DCD when talking to family members. First, you must get the family member's consent to even do an evaluation on the candidate for organ suitability. There are a number of things that go into this, considering the patient's age, the medications that they are taking, their respiratory drive, and other things. These things are listed in the educational handout that has been provided to you. Overall, they use the collaborative practice critical pathway to determine what candidates would be eligible. The patient here with us today, Mr. Smith, has been evaluated and deemed a suitable candidate. I am about to speak with his family member in anticipation of his brother's death. Mr. Smith, as we have talked about before, and you've agreed to donate your organs in anticipation of him passing away, our evaluation tool tells us that he is a good candidate for organ donation. Because of that, there are a couple drugs that we will need to administer to him that we would not normally. These are heparin and phenethylamine. Heparin will help to prevent the clotting in the blood vessels, whereas phenethylamine will help to prevent the blood vessels from spasming. It's important that you know that these are not to hasten death, but just to help with the organ procurement and organ function. In order to recover more organs, it is optimal, although not required, to withdraw life support here in the operating room. This allows to procure the organs with the least amount of ischemia. In a few minutes, we anticipate that your brother will have a cardiac arrest and we will see a flat line on the monitor. When this occurs, the physician will call time of death, and we will need to wait approximately 2 to 10 minutes to ensure that there will not be auto-resuscitation before we can begin surgical recovery. Because he is under 50 years of age, we will attempt to procure the kidneys, the liver, the lungs, and the pancreas. At this time, would you like to stay while we withdraw support?
No, thank you.
Thank you, Mr. Smith. We will now extubate the patient and stop all present medications. And we do anticipate Mr. Smith to have a cardiac arrest soon. An important part of cardiac death and organ procurement is not just the ECG monitoring, but more importantly, the arterial line monitoring. This determines our time of death and our cardiac death, and begins our 2-minute waiting period before surgical recovery can begin. When the observation time is over, and it is apparent that resuscitation will not occur, we will begin the flushing preservation solutions. We will begin this at this time as 2 minutes has elapsed. This is called our cold preservation. From extubation to the start of cold solution perfusion is called the warm ischemic time. Accurate record keeping of this timetable helps determine which organs are suitable for transplantation. Remember that the withdrawal of life support could occur away from the operating room and would lengthen the warm ischemic time. We will begin surgery. If a warm ischemic time takes less than 30 minutes, then the liver, the lungs, the pancreas, and the kidneys can all be recovered. If it takes more than 30 minutes, then you may not recover the liver. If it takes more than 45 minutes, you may not recover the pancreas. Today we've been able to recover the lungs. There are some other things to remember about DCD. The best candidates for DCD are those that are ALS patients, patients with high spinal cord injuries between the C1 and the C4, or that are ventilator dependent, or patients with significant cardiopulmonary disease. Remember that 5 to 10% of patients that are deemed DCD suitable will not die within the time frame required for DCD after withdrawal from life support. There are also a number of things to remember as a nurse dealing with one of these patients. First, remember that these are patients and that the family will need support. Even though the family has decided to give the gift of life to someone else, they have also lost the life. Once consent is obtained to do the assessment for DCD, then you should continue your end-of-life care. If it is also deemed not suitable, a not suitable candidate, then continue your end-of-life care. If life support is withdrawn for a DCD candidate, continue with the patient and be with them during withdrawal of support. And above all, know and follow your institution's protocols on all of these matters. If you have any other questions about donation after cardiac death, please refer to the educational materials that have been provided to you. Thank you very much.